Hello everyone, and welcome to another stream of Advanced Pharmacology. Today we'll be discussing Chapter 40, Drugs for Heart Failure. So, drugs for heart failure. Heart failure is a disease with two major forms. Heart failure with left ventricular systolic dysfunction, now referred to as heart failure with a reduced ejection fraction, and diastolic heart failure, also known as a heart failure with a preserved left ventricular ejection fraction. In this chapter, discussion is limited in the first form. Accordingly, for the rest of the chapter, the term heart failure will be used to denote the first form only. Again, the first form is ventricular systolic dysfunction, which has a reduced ejection fraction. Heart failure is a progressive, often fatal disorder characterized by ventricular dysfunction, a reduced cardiac output, insufficient tissue perfusion, and signs of fluid retention via peripheral edema, shortness of breath. The disease affects nearly 5 million Americans and every year is responsible for 12 to 15 million office visits, 6.5 million hospital days, and about 300,000 deaths. Of those who have heart failure, 20% are likely to die within 1 year, 50% within 5 years. Heart failure is primarily a disease of the older adult, affecting 4 to 8% of those at age 65 and older, and more than 9 to 12% of those older than 80 years of age. Direct and indirect healthcare costs of heart failure are estimated at more than $34 billion yearly. With improved evaluation and care, many hospitalizations could be prevented, the quality of life could be improved, and the life expectancy could be extended. In the past, heart failure was commonly referred to as congestive heart failure. This term was used because heart failure frequently caused fluid accumulation or congestion in the lungs and peripheral tissue. However, because many patients do not have the signs of pulmonary or systemic congestion, the term heart failure is now preferred. Drugs recommended for the treatment include diuretics, inhibitors of the Renin-Angiotensin-Aldosterone system, beta blockers, and digoxin. In this chapter, only digoxin is discussed at length. The other drugs are presented at length in previous chapters, so discussion here is limited to their use in heart failure only. To understand heart failure and its treatment, you need a basic understanding of the hemodynamics. In particular, you need to understand the role of venous pressure, afterload, and Starling's mechanism in determining cardiac output. You also need to have an understanding of the roles of the baroreceptor reflex, the RAS, and the kidneys in regulating arterial pressure. Again, all that was discussed in chapter 34 already, and you're welcome to look at that in further detail as it's already a chapter I have posted. Pathophysiology of the heart failure. Heart failure is a syndrome in which the heart is unable to pump sufficient blood to meet the metabolic needs of the tissues. The syndrome is characterized by signs of inadequate tissue perfusion, such as fatigue, shortness of breath, exercise intolerance, and/or signs or symptoms of fluid volume overload, venous distension, peripheral and pulmonary edema. The major underlying causes of heart failure is the chronic hypertension and myocardial infarction. Other causes include valvular heart disease, coronary artery disease, congenital heart disease, dysrhythmias, and aging of the myocardium. In its earliest stage, heart failure is considered asymptomatic. As failure, however, progresses, fatigue and shortness of breath begins to develop. As cardiac performance, however, starts to decline, blood backs up behind the failing ventricles, causing a venous distension, peripheral edema, and pulmonary edema. Heart failure is a chronic disorder that requires continuous treatment with medications. So, cardiac remodeling. In the initial phase of failure, the heart undergoes remodeling, a process in which the ventricles begin to dilate, hypertrophy, and become more spherical. These alterations in cardiac geometry increase wall stress and reduce left ventricular ejection fraction. Remodeling occurs in response to cardiac injury brought on by the infarction and of other causes. The remodeling process is driven primarily by the neurohormonal systems, including the sympathetic nervous system and the RAS system. In addition to promoting remodeling, neurohormonal factors promote cardiac fibrosis and myocyte death. The net result of these pathologic changes, remodeling, fibrosis, and cell death, is progressively decline in cardiac output. As a result, cardiac remodeling precedes development of symptoms and continue after they appear. As a result, cardiac performance continues to decline. Which brings us to the physiologic adaptations to reduced cardiac output. In response to the reductions in cardiac pumping ability, the body undergoes several adaptive changes. Some of these help improve tissue perfusion. Other compounds existing problems. Your cardiac dilation. The dilation of the heart is characteristic of heart failure. Cardiac dilation results from a combination of increased venous pressure and reduced contractile force. Reduced contractility lowers the amount of blood ejecting during systole, causing end-systolic volume to rise. The increase in venous pressure increases diastolic filling, which causes the heart to begin to expand even further. Because of Starling's mechanism, the increase in heart size that occurs in heart failure helps improve cardiac output. That is, as the heart fills and its volume expands, contractile force increases, causing a corresponding increase in the stroke volume. However, please note that the maximal contractile force that can be developed by the failing heart is considerably lower than the maximal force of a healthy heart. This limitation is reflected in the curve for a failing heart shown in the following figure. So here is an excellent spot to hit pause so you can see the differences between a normal, a failure plus digoxin, and just a failure in the contractile force of a heart. If cardiac dilation is insufficient to maintain cardiac output, other factors start to come into play, which, as discussed later, these are not always beneficial. So, an increased sympathetic tone, heart failure, causes arterial pressure to fall. In response, the baroreceptor reflex increases the sympathetic output to the heart, the veins, and arterioles. At the same time, the parasympathetic effects on the heart start to get reduced. The consequence of an increased sympathetic tone are summarized here. So the first, an increased heart rate. The acceleration of the heart rate increases the cardiac output, therefore helping improve tissue perfusion. However, if heart rate increases too much, there will be insufficient time for complete ventricular filling, and cardiac output will fall. Increased contractility. Increased myocardial contractility has the obvious benefit of increasing the cardiac output. The only detriment is an increase in cardiac oxygen demand. Increase venous tone. The elevation of venous tone increases venous pressure and therefore increases ventricular filling. Because of Sterling's mechanism, increased filling increases stroke volume. Unfortunately, if the venous pressure is excessive, blood starts to back up behind the failing ventricle, thereby aggravating pulmonary and peripheral edema. Furthermore, excessive filling pressure can dilate the heart so much that the stroke volume starts to begin to decline. Increased arteriolar tone. The elevation of arteriolar tone increases arterial pressure, therefore increasing perfusion of vital organs. Unfortunately, increased arterial pressure also means the heart pump against greater resistance. Because cardiac reserve is minimal in heart failure, the heart may be unable to meet this challenge and output starts to fall. Water retention and increased blood volume. Its mechanism. So, water retention results from two mechanisms. The first, reduced cardiac output, causes a reduction in renal blood flow, which in turn decreases your glomerular filtration rate, or GFR. As a result, urine production is decreased and water is retained. Second, heart failure activates the RAS system. Activation occurs in response to a reduced blood pressure and reduced renal blood flow. So, when activated, the RAS promotes water retention by increasing circulating levels of aldosterone and angiotensin II. Aldosterone acts directly on the kidneys to promote that retention of sodium and water. Angiotensin II causes the constriction of renal blood vessels, which decreases renal blood flow and therefore further decreases urine production. In addition, angiotensin II causes the constriction of the systemic arterioles and veins and therefore increases the venous and arterial pressure. So what is the consequence to that? As with other adaptive responses to heart failure, increased blood volume can be beneficial or harmful. Increased blood volume increases venous pressure and therefore increases venous return. As a result, ventricular filling and stroke volume are increased. The resultant increase in cardiac output can improve tissue perfusion. However, again, as noted, if venous pressure starts to become too high, edema of the lungs and periphery may result. More importantly, if the increase in cardiac output is insufficient to maintain adequate kidney function, renal retention of water will progress unabated. The resultant accumulation of fluid will cause severe cardiac, pulmonary, and peripheral edema, which will all lead to death. So your natriuretic peptides. In response to stretching of the atria and the dilation of the ventricles, the heart releases two natriuretic peptides, your atrial natriuretic peptide, or ANP, and the B-Natriuretic peptide, or BNP. Again, these were discussed in closer detail in chapter 34, but these hormones promote the dilation of arterioles and veins and also promote loss of sodium and water through the kidneys. Therefore, they tend to counterbalance vasoconstriction caused by the SNS and angiotensin II, as well as the retention of sodium and water caused by the RAS system. However, as heart failure progresses, the effects of ANP and BNP eventually become overwhelmed by the effects of the SNS and the RAS system. Levels of circulating BNP are an important index of cardiac status in heart failure. Patients and thus can be a predictor of a long-term survival. High levels of BNP indicate poor cardiac health and can predict a lower chance of survival. Conversely, low levels of BNP indicate a better cardiac health and can predict a higher chance of survival. This information can be helpful when assessing the hospitalized patient at discharge. The lower the BNP level, the greater the chance of long-term survival. The viciousness cycle of the compensatory physiologic response, therefore. Again, as discussed previously, a reduced cardiac output leads to compensatory responses. Again, that cardiac dilation, the activation of the SNS, the activation of the RAS system, retention of water, and the expansion of blood volume. Although these responses represent the body's attempt to compensate for a reduced cardiac output, they can actually make matters worse. Excessive heart rate reduces ventricular filling. Excessive arterial pressure can lower cardiac output, and excessive venous pressure can cause pulmonary and peripheral edema. Therefore, as depicted in figure 40.2, the compensatory responses can create a self-sustaining cycle of maladaptation that further impairs cardiac output and tissue perfusion. If cardiac output becomes too low to maintain a sufficient production of urine, The resultant accumulation of water will eventually be fatal. The actual cause of death is complete cardiac failure, secondary to excessive cardiac dilation and cardiac edema. So here's this figure that they're talking about. Again, it's a good spot to hit pause to see maybe a physical photo of what we're talking about here. It's nice that I say all this stuff aloud. However, a picture does say, something different. In the same way that is. So, your signs and symptoms of heart failure. The prominent signs and symptoms of heart failure are a direct consequence of the pathophysiologic actions that were just described. A decreased tissue perfusion results in reduced exercise tolerance, fatigue, and shortness of breath. Shortness of breath may also reflect pulmonary edema. Increased sympathetic tone produces tachycardia. Increased ventricular filling reduces systolic ejection and myocardial hypertrophy, which results in cardiomegaly, or an increased heart size. The combination of increased venous tone plus increased blood volume helps cause pulmonary edema, peripheral edema, hepatomegaly, and distension of the jugular veins. Weight gain from that fluid retention. So the classifications of heart failure severity. There are two major schemes for classifying heart failure severity. One is established by the New York Heart Association, which classifies heart failure based on the functional limitations it causes. A newer scheme proposed jointly by the American College of Cardiology and the American Heart Association is based on the observation that heart failure is a progressive disease that moves through stages of increasing severity. So, the New York Heart Association scheme, which has 4 classes, can be summarized as the following. Class 1, no limitation on your ordinary physical activity. Class 2 has a slight limitation of physical activity. Normal activity produces some fatigue, dyspnea, maybe palpitations, or possible angina. Class 3 has marked limitation of physical activity. Even mild activity will produce symptoms. And then finally, Class 4, symptoms occur even when you are resting. Whereas the American College of Cardiology and the American Heart Association scheme also has 4 stages, and they are summarized slightly different. So, for instance, stage 1 or stage A, at high risk for heart failure, but without structural heart disease or symptoms of heart failure. Stage B, or stage 2, structural heart disease, but without symptoms of heart failure. Stage C, or 3, depending on if you like the 1, 2, 3 method, structural heart disease with prior or current symptoms of heart failure. And finally, stage D, or stage 4, would be refractory heart failure, requiring specialized interventions. So, the American College of Cardiology and American Heart Association scheme was unveiled in the treatment guideline issue in 2001. The newest version of the document is the 2013 ACCF/AHA guideline for the management of heart failure. Please note again that the ACC/AHA scheme is intended to complement the New York Heart Association scheme, not necessarily replace it rather. The relationship between the two are seen here in the following figure. And again, it's a good spot to hit pause so you can kind of see where one starts and another technically ends. But they both were pretty much hand in hand. So, overview of drugs used to help treat heart failure. For routine therapy, heart failure is treated with 3 types of drugs. Again, those that would best benefit. So, your diuretics, your agents that would inhibit the RAS system, and beta blockers. However, there are also other agents. Again, your digoxin, your dopamine, and hydralazine can all be part of that treatment modality window. So let's start off with diuretics. Diuretics is the first-line drug for all patients who have signs of fluid volume overload or with a history of volume overload. By reducing blood volume, these drugs can decrease the venous pressure, the arterial pressure or afterload, pulmonary edema, peripheral edema, and decrease that cardiac dilation. However, excessive diuresis must be avoided. If blood volume drops too low, cardiac output and blood pressure may fall precipitously, thereby further compromising tissue perfusion. For the most part, the benefit of diuretics are limited to symptom reduction. So as a rule, these drugs do not prolong survival. The basic pharmacology of a diuretic is discussed in more detailed information in chapter 35. So, there are different types of diuretics. Your thiazide diuretic, which would be your hydrochlorothiazide, for instance, produces moderate diuresis. These oral agents are used for long-term therapy of heart failure when edema is not too great. Because thiazides are ineffective when you have a low GFR, these drugs cannot be used if cardiac output is greatly reduced. The principal adverse effect of thiazides is hypokalemia, which increases the risk for a digoxin-induced dysrhythmia. And we'll discuss that a little bit later. Your loop diuretics. Loop diuretics such as Lasix or furosemide produce profound diuresis. In contrast to thiazides, these drugs can promote fluid loss even if you have an already low GFR. Therefore, a loop diuretic is preferred to a thiazide when cardiac output is greatly reduced. Because they can mobilize large volumes of water, and because they can work well even if you have a low GFR, loop diuretics are a great choice of drug for patients who already have severe heart failure. Similar to thiazides, these drugs can cause hypokalemia. There is again that increased risk for a digoxin toxicity. So, in addition to loop diuretics that can cause severe hypotension secondary to excessive volume reduction, because they work so well even if you don't have that low GFR. Which brings us to the last series, the potassium-sparing diuretics. In contrast to your thiazides and loop diuretics, your potassium-sparing diuretics, your spironolactone or aldactone, and your triamterene can promote only scant diuresis. In patients who have heart failure, these drugs are employed mostly to counteract potassium loss caused by a thiazide or a loop diuretic, thereby lowering the risk for digoxin-induced dysrhythmias. Not surprisingly, the principal adverse effect of a potassium-sparing drug is therefore hyperkalemia. Because angiotensin-converting enzymes, such as your ACE inhibitors and angiotensin II receptor blockers, your ARBs, also carry a risk for hyperkalemia, caution is needed if these drugs are combined together with a potassium-sparing diuretic. Accordingly, when therapy with an ACE inhibitor and an ARB is initiated, the potassium-sparing diuretic should be discontinued. It can be resumed later if needed. One potassium-sparing diuretic, aldactone, prolongs survival in patients who have heart failure, primarily by blocking receptors for aldosterone, not by causing any type of diuresis in that sense. This drug and a related agent, eplerenone, will be discussed later under aldosterone antagonists. So, let's start off by talking about some drugs. Drugs that inhibit the renin-angiotensin-aldosterone system. The RAS system plays an important role both in the cardiac remodeling and in hemodynamic changes that can occur in response to a reduced cardiac output. Accordingly, agents that inhibit the RAS system can be highly beneficial. So there are four groups of drugs that are available. The first, your ACE inhibitors, followed by your ARBs, followed by direct renin inhibitors or DRIs, and finally your aldosterone antagonists. Of the four, ACE inhibitors have been studied the most thoroughly in patients who have heart failure. The basic pharmacology of the RAS inhibitors was already presented in chapter 36. Feel free to click on over and listen to that. We will have, however, some prototype drugs here for heart failure, and they include your inhibitors of the Renin-Angiotensin-Aldosterone system or RAS system, your captopril, your losartan, your eplerenone. We'll also again speak more on diuretics, your hydrochlorothiazides and Lasix, your inotropic agents such as digoxin, and as always, we'll talk on some beta blockers, which is mostly your metoprolol. So we'll start off with those ACE inhibitors, your angiotensin converting enzyme inhibitors. Your ACE inhibitors, your captopril, your enalapril, are the cornerstones of heart failure therapy. These drugs can improve functional status and prolong life. In one trial, the 2-year mortality rate of patients taking enalapril was 47% lower than the rate for patients who take a placebo. Other large controlled trials have shown similar benefits. Accordingly, in the absence of specific contraindications, all patients with heart failure should receive one of these drugs. Although ACE inhibitors can be used alone, they are usually combined with a beta blocker and a diuretic. Your ACE inhibitors block the production of angiotensin II, a decrease release of aldosterone, and suppress the degradation of kinins. As a result, they improve your hemodynamics and favorably alter cardiac remodeling. So, hemodynamic benefits. By suppressing the production of angiotensin II, ACE inhibitors cause the dilation of the arterioles and veins, and they decrease the release of aldosterone. Resulting benefits of heart failure are as follows. So, a couple benefits. Your arteriolar dilation. Again, it improves the regional blood flow in the kidneys and other tissues. And by reducing the afterload, it increases stroke volume and cardiac output. Increased renal blood flow promotes excretion of sodium and water. Second benefit, your venous dilation. It reduces the venous pressure and therefore reduces pulmonary congestion, peripheral edema, your preload, and cardiac dilation. And again, the last benefit, the third one, the suppression of aldosterone release, which enhances the excretion of sodium and water while causing the retention of our potassium. Interestingly, suppression of angiotensin II production diminishes over time, suggesting that long-term benefits are the result of some other action. The influence on cardiac remodeling. With continued use, an ACE inhibitor has a favorable influence on cardiac remodeling. The elevation of kinins is largely responsible. The statement is based in part of the observation that in experimental models, giving a kinin receptor blocker decreases beneficial effects on remodeling. Also, we know that the suppression of angiotensin II production diminishes over time, so the reduced angiotensin II cannot fully explain a long-term benefit. Again, there are always adverse effects for any medication. So the principal adverse effect of ACE inhibitors would be hypotension, secondary due to that arteriolar dilation. Hyperkalemia, again, because we have that decreased aldosterone release. There is the potential for an intractable cough and angioedema. In addition, these drugs can cause renal failure in patients with a bilateral renal artery stenosis. Because of their ability to elevate potassium levels, ACE inhibitors should be used with caution in a patient taking potassium supplements or are on a potassium-sparing diuretic. Again, your aldactone or spironolactone. ACE inhibitors come with a big black box warning. So, inhibitors, or ACE inhibitors rather, for use during pregnancy. The use of ACE inhibitors during pregnancy, especially during that second and or third trimester, will cause fetal harm. So, they should not ever be used in a patient who is pregnant or potentially pregnant. And the medication should be discontinued if we suspect that the patient may be pregnant. Dosage. Adequate dosage is still debated in the literature. A higher dosage may be associated with an increased survival, but there is conflicting evidence that truly, states that. Results of the assessment of treatment with lisinopril and survival, or the ATLAS trial, indicates that the dosage needed to increase survival are higher than those needed to produce a hemodynamic change. In contrast to the ATLAS trial, the network trial and the high-dose enalapril study group did not find a difference in the mortality between patients on a low dose versus a high dose of ACE inhibitors. So treatment with an ACE inhibitor should be initiated at a low dose and slowly titrated upward. And if a patient's tolerance treatment, target dosages associated with a disease modification are shown here in the following table, and these dosages should be used unless a side effect makes them intolerable. So there are a series of dosages here, as well as different medications listed. So it's an excellent spot to hit pause and read them over. But I will keep moving on. So we'll start talking on angiotensin II receptor blockers. Your angiotensin II receptor blockers, also known as ARBs, are similar to those of ACE inhibitors. However, they're not 100% identical, so your hemodynamic effects of both groups are much the same. Clinical trials have shown that ARBs improve the left ventricular ejection fraction. They reduce heart failure symptoms, increase exercise tolerance, and decrease hospitalization. They enhance the overall quality of life, and most importantly, they reduce mortality. However, because ARBs do not increase levels of kinins, their effects on cardiac remodeling are less favorable than those of an ACE inhibitor. For that reason, and because clinical experience with ACE inhibitors is much greater than with ARBs, ACE inhibitors are generally preferred. For now, ARBs should be reserved for heart failure patients who cannot tolerate an ACE inhibitor, usually owing to intractable cough. Because ARBs do not increase bradykinin levels, they do not cause that cough. Bringing us to the next section, the angiotensin receptor neprilysin inhibitors. So, there are there's one major medication here listed. Most commonly known as Entresto, for those who work on a cardiac unit. However, its trade name is sacubitril/valsartan. We just call it Entresto. Entresto is a newly approved drug that functions in two different manners. The first section of it is the sacubitril, which is a new class of drug called an angiotensin receptor neprilysin inhibitor, or ANRI. So in simple terms, Entresto increases the natriuretic peptides while suppressing the negative effects of the RAS system. As discussed earlier in the chapter, your ANP and your BNP are important indicators of cardiac status in your heart failure patients. Entresto is approved for patients with stage 2 to 4 heart failure to be used in place of an ACE inhibitor or an ARB. In the Paradigm heart failure study, Entresto was superior to enalapril alone when looking at the overall endpoints of the reduction in hospitalizations, risk for all-cause mortality, and risk for death from cardiovascular causes. In fact, the study was terminated early because of the overwhelming positive results. Because Entresto contains an ARB, the contraindications and side effects are similar. Entresto can cause angioedema, hyperkalemia, and hypotension. The administration again should be avoided in pregnancy because it can cause that fetal harm. And it's again because it has that ARB portion of the medication. So we'll start talking about aldosterone antagonists. In patients with heart failure, aldosterone antagonists, your aldactone or spironolactone, and your Inspira or eplerenone, can reduce symptoms, decrease hospitalization, and prolong life. These benefits were first demonstrated with aldactone in the randomized aldactone evaluation study. Similar results were later again obtained with the medication eplerenone. So current guidelines recommend adding an aldosterone antagonist to standard heart failure therapy, but only in patients with a persistent symptom despite adequate treatment with an ACE inhibitor and a beta blocker. Aldosterone antagonists work primarily by blocking aldosterone receptors in the heart and blood vessels. To understand these effects, we need to review the role of aldosterone in heart failure. In the past, researchers believed that all aldosterone did was promote renal retention of sodium and water in exchange for the excretion of potassium. However, we now understand that aldosterone has additional and more harmful effects, including the following. So the big ones here are the first five we're going to talk about. The first, the promotion of myocardial remodeling, which impairs the pumping aspect of the heart. The promotion of myocardial fibrosis, which increases the risk for a dysrhythmia. The activation of the SNS and suppression of norepinephrine uptake in the heart, both of which can again promote that dysrhythmia and now ischemia. The fourth, the promotion of vascular fibrosis, which decreases your arterial compliance. And lastly, the promotion of the baroreceptor dysfunction. Again, we need that baroreceptor to help balance out your blood pressure. So during heart failure, the activation of the RAS system causes the levels of aldosterone to rise. In some patients, levels reach 20 times the normal. As aldosterone levels grow higher and higher, the harmful effects begin to increase and your prognosis becomes progressively worse. So, drugs can reduce the effects of aldosterone by either decreasing aldosterone production or blocking the aldosterone receptors, negating its effect. So, your ACE inhibitors, your ARBs, your DRIs, they all decrease aldosterone production. However, your spironolactone and eplerenone block the aldosterone receptor sites. Although ACE inhibitors and ARBs can reduce aldosterone production, they don't block it at the receptor site entirely. And they also don't block the production of aldosterone entirely. So furthermore, the production is suppressed only for a relatively short time. Therefore, when an ACE inhibitor or an ARB is used alone, your detrimental effects of aldosterone can still persist. However, when an aldosterone antagonist is added to the regimen, any residual effects start to get eliminated, and as a result, your symptoms of heart failure improve and your life is prolonged. Aldosterone antagonists have, however, one major adverse effect, and that is your hyperkalemia. The underlying cause is because of renal retention of potassium. The risk is increased by renal impairment and by the use of an ACE inhibitor or an ARB. So to minimize this risk, potassium levels and renal function should be measured at baseline and periodically throughout use. Your potassium supplements ought to be tossed aside for the time being and discontinued. Aldactone, but not eplerenone, poses a significant risk for gynecomastia, or breast enlargement, especially in your male patient population, a condition that can be both cosmetically troublesome and painful. In a Rails trial, 10% of males experienced painful breast enlargement. So, aldactone does have a black box warning. Again, it's associated with tumorigenesis in studies completed on rats. Which takes us now to the DRIs, which again stand for direct renin inhibitors. These were discussed in Chapter 36. DRIs can shut down the entire RAS system. In theory, the benefit of heart failure should equal those of the ACE inhibitor and the ARBs. At this time, though, we have one DRI, aliskiren, which is available. In a recent trial, aliskiren did not improve outcomes in hospitalized patients with heart failure. Additional studies on aliskiren are being conducted currently. Because of these findings, aliskiren is approved for hypertension, but not yet approved for heart failure. Keep in mind, this text is now almost close to 10 years old, so keep in mind this might be outdated at this point. Your beta blockers. The role of beta blockers in heart failure continues to evolve. Until the mid-1990s, heart failure was considered an absolute contraindication to these drugs. After all, a blockade of cardiac beta-1 adrenergic receptors reduce contractility, an effect that is clearly detrimental, given that contractility is already compromised in the failing heart. However, it is now clear that with careful control over dose, beta blockers can improve your patient's status. Control trials have shown that 3 beta blockers, and the big ones here are carvedilol or Coreg, bisoprolol or Subbeta, and a sustained-release metoprolol or Toprol XL, when added to the conventional therapy, actually can improve your left ventricular ejection fraction, increase exercise tolerance, slow progression of heart failure, and reduce the need for hospitalization, and most importantly, therefore, prolonged life and survival. Accordingly, beta blockers are now recommended as a first-line therapy for most patients. These drugs can even be used in patients with severe disease, provided the patient is euvolemic and hemodynamically stable. Although the mechanism underlying the benefits is still uncertain, likely possibilities include protecting the heart from excessive sympathetic stimulation and protecting it against fatal dysrhythmias. Because excessive beta blockade can reduce contractility, doses must be very low initially and gradually tapered back up. Full benefits may not be seen in the first 1 to 3 months. So it may take some time to adjust a dose to its proper dosage and get the most benefit. Among patients with heart failure, the principal adverse effects are fluid retention and potentially worsening of heart failure, fatigue, hypotension, and bradycardia, or even a complete heart block. The basic pharmacology of beta blockers, again, was already discussed in Chapter 14. So please make sure you check that out. Whoop. Which brings us to our next medication, ivabradine, also known as Corlenor. In 2015, the FDA approved ivabradine for use in patients who have stable, symptomatic heart failure, a left ventricular ejection fraction that is less than 35% in sinus rhythm, and a heart rate that was greater than 70 beats per minute, on a maximally tolerated dose of beta blockers, and who have contraindications to beta blocker use. Because it's still relatively new and not included in the current treatment guidelines, we only discussed this medication briefly. Ivabradine causes a dose-dependent reduction in heart rate by blocking the channels responsible for cardiac pacemaker current. Although the drug slows the heart rate, it does not possess negative inotropic effects or cause any type of QTc prolongation. When used in a recommended dose, the heart rate reduction is approximately 10 beats per minute. So, the SHIFT study, which is the systolic heart failure treatment with the I inhibitor ivabradine trial, study was a randomized double-blind trial comparing ivabradine to a placebo medication in about 6,500 and some adults. The end result revealed that the ivabradine reduced risk of hospitalization for worsening heart failure or cardiovascular death. Given these findings, ivabradine may be a useful alternative for patients with heart failure who need additional beta blockade above what is already currently available. Which now takes us to digoxin. Digoxin belongs in a class of drugs known as a cardiac glycoside, agents best known for their positive inotropic action, which is their ability to increase the myocardial contractile force. By increasing contractile force, digoxin can increase cardiac output. In addition, it can also alter the electrical activity of the heart and can favorably affect neurohormonal systems. Unfortunately, although digoxin can reduce symptoms of heart failure, it is not known to prolong life. Used widely in the past, digoxin is considered a second-line agent today. The pharmacology of this medication will be discussed a little later. Bringing us to vasodilators, other than ACEs or ARBs. Other than ACE inhibitors and ARBs. So the first is your isorzabide dinitrate plus hydralazine. For the treatment of heart failure, your isorzabide dinitrate and hydralazine are usually combined. This combination represents an alternative to an ACE inhibitor or ARB. However, ACE inhibitors and ARBs are generally preferred. So, the medication we're talking about is known as isordil, which belongs to the same family as nitroglycerin. Similar to nitroglycerin, isordil causes selective dilation of veins. In patients with severe refractory heart failure, the drug can reduce congestive symptoms and improve exercise capacity. In addition to its hemodynamic actions, isordil may inhibit abnormal myocyte growth and thus delay cardiac remodeling. Your principal adverse effects of your orthostatic hypotension and reflex tachycardia, the basic pharmacology of isordil and other organic nitrates, will be discussed in Chapter 43. Hydralazine, also known as apresoline, causes selective dilation of arterioles. By doing so, the drug can improve cardiac output and renal blood flow. For treatment of heart failure, hydralazine is always used in combination with isordil because hydralazine by itself is not very effective. Principal adverse effects include hypotension, tachycardia, and a syndrome that resembles systemic lupus erythematosus. The basic pharmacology of hydralazine was already discussed in Chapter 38. Bidil. Bidil is a fixed-dose combination of hydralazine and isorbil, as approved for treating heart failure, but only in your African Americans, making Bidil the first medication approved for a specific ethnic group. So the question comes then, can Bidil help people in other ethnic groups? Probably, but data is currently lacking, and the manufacturer only tested the product on Black patients, which is questionable if you think about that for longer than 2 seconds. And as discussed in Chapter 6, testing was limited primarily because of the regulatory and market incentives, not because there was data suggesting it wouldn't work for others. Of course, now that Bidil is approved, clinicians may prescribe it for anyone they see fit. Each Bidil tablet contains 37.5 milligrams of hydralazine and 20 milligrams of isorbil. Again, the recommended dosage is 1 or 2 tablets about 3 times a day. Which brings us now back to digoxin, which I'm not sure why they decided to split this into 2 sections here. But digoxin, also known as lanoxin, belongs to a family of drugs again known as cardiac glycosides. Again, these drugs are prepared by extraction of digitalis purpurea, also known as purple foxglove, and digitalis lanata, or Grecian foxglove, and therefore are also known as digitalis glycosides. In the US, digoxin is the only cardiac glycoside available. Digoxin has profound effects on the mechanical and electrical properties of the heart. In addition, it has important neurohormonal effects. In patients with heart failure, benefits derive from increased myocardial contractility and from effects on your neurohormonal system. Digitalis is a dangerous drug because at doses close to therapeutic, it can cause severe dysrhythmias. Owing to its pro-dysrhythmic action, digoxin must be used with respect, caution, and skill. Digoxin is indicated for heart failure and for the control of a dysrhythmia. Again, we'll discuss that more in chapter 41. When used for heart failure, digoxin can reduce symptoms, increase exercise tolerance, and decrease hospitalizations. However, the drug does not prolong life. Furthermore, when used in women, it may actually shorten life. Because its benefits are limited to symptomatic relief, and because the risk for toxicity is substantial, digoxin is now considered a second-line drug for treating heart failure. Which brings us to chemistry. Digoxin consists of three components: a steroid nucleus, a lactone ring, and a three-molecule of digitoxose, or sugar. It is because of the sugars that digoxin is known as a glycoside. The region of the molecule composed of the steroid nucleus plus the lactone ring is responsible for the pharmacologic effect of digoxin. The sugars only increase the solubility. Its mechanical effects on the heart, therefore. Digoxin exerts a positive inotropic action on the heart, which means that the drug increases the force of ventricular contraction and can thereby increase cardiac output. So how does the mechanism of inotropic action actually work? So, digoxin increases the myocardial contractility by inhibiting an enzyme known as sodium potassium adenosine triphosphatase, also known as your sodium potassium ATPase. By the way of an indirect process described a little later, the inhibition of the NAK ATPase promotes the calcium accumulation within the myocytes. The calcium then augments the contractile force by facilitating the interaction of myocardial contractile proteins, both actin and myosin. To understand how the inhibition of your sodium-potassium ATPase causes intracellular calcium to rise, we must first understand the normal role of sodium-potassium ATPase in myocytes. That is shown in the following figure 40.4, which indicates when an action potential passes along the myocyte membrane, your sodium ions and your calcium ions enter the cell and your potassium ions exit. After the action potential passes, these ions fluxes must be reversed so the original ionic balance of the cell can be restored. So sodium, potassium, and ATPase is critical to this process. Your sodium-potassium ATPase act as a pump to draw the extracellular potassium ions into the cell, while simultaneously extruding intracellular sodium. The energy required for pumping sodium and potassium is provided by the breakdown of ATP. Therefore, its name is given, that sodium-potassium ATPase. To complete the normalization of the cellular ionic composition, calcium ions must also leave the cell. The extrusion of calcium is accomplished through the exchange process, in which extracellular sodium ions are taken into the cell, while your calcium ions exit. This exchange for sodium for, or the exchange of sodium for calcium is a passive process, which is why there is no ATP required. So here is a picture version of what I just said. An excellent spot to hit pause if you need that picture to explain that a little better. So we can now answer the question, how does the inhibition of sodium-potassium ATPase increase intracellular calcium. By inhibiting sodium-potassium ATPase, digoxin prevents the myocyte from restoring its proper ionic composition following the passage of an action potential. The inhibition of sodium-potassium ATPase blocks the uptake of potassium and the extrusion of sodium. Therefore, with each successive action potential, your intracellular potassium levels decline and your intracellular levels of sodium rise. It's that rise in sodium that leads to the rise in intracellular calcium. In the presence of excessive intracellular sodium, further sodium entry is suppressed. Because sodium entry is suppressed, the passive exchange of calcium for sodium cannot take place. So calcium starts to accumulate within the cell. So what's the relationship of potassium then to inotropic action? Potassium ions compete with digoxin for the binding to sodium-potassium ATPase. This competition is of great clinical significance. Again, because potassium competes with digoxin. When potassium levels are low, the binding of digoxin to that sodium-potassium ATPase increases. Again, this increase can produce excessive inhibition of that sodium-potassium ATPase with a resultant toxicity. Conversely, when the levels of potassium are too high, the inhibition of your sodium-potassium ATPase by digoxin is reduced, causing a reduction in a therapeutic response. Because an increase in potassium can impair therapeutic responses, whereas a decrease in potassium can cause toxicity, it's really important that we keep an eye on our potassium levels and make sure they stay within a normal physiologic range of 3.5 to 5 MEq. So, hemodynamic benefits in heart failure. Increased cardiac output. In patients with heart failure, increased myocardial contractility increases cardiac output. By increasing contractility, digoxin shifts with the relationship of fiber length to stroke volume in the failing heart toward that in the healthy heart. So, at any given heart size, the stroke volume of the failing heart increases, causing a cardiac output to rise. Consequences of increased cardiac output, therefore. As a result of increased cardiac output, three major secondary responses begin. The sympathetic tone declines, your urine production increases, and the renin release declines. These responses can reverse virtually all signs and symptoms of heart failure. However, they do not correct the underlying problem of the cardiac remodeling. So, decreased sympathetic tone. By increasing contractile force and cardiac output, digoxin increases arterial pressure. In response, your sympathetic nerve traffic to the heart and the blood vessels is reduced through the baroreceptor reflex. The decrease in sympathetic tone has several beneficial effects. First, the heart rate is reduced, thereby allowing more complete ventricular filling. Secondly, the afterload is reduced, thereby allowing more complete ventricular emptying. And finally, third, venous pressure is reduced, thereby reducing cardiac distension, pulmonary congestion, and peripheral edema. Increased urine production. The increase in cardiac output increases renal blood flow and therefore increases the production of urine. The increased production of urine means that there is a resultant loss of water, reduces blood volume, which in turn reduces cardiac distension, pulmonary congestion, and peripheral edema. We're getting rid of that urine or the excess fluid. Decreased renin release. Again, in response to increased arterial pressure, renin release declines, causing levels of aldosterone and angiotensin II to decline as well. This decrease in angiotensin II decreases vasoconstriction, therefore further reducing your afterload and venous pressure. The decrease in aldosterone reduces retention of sodium and water, which also reduces blood volume, which in turn further reduces venous pressure. So, in summary of your hemodynamic effect, we can see that through the direct and indirect mechanisms, digoxin has the potential to reverse all of the overt manifestations of heart failure. Cardiac output improves, your heart rate decreases, your heart size declines, the constriction of the arterioles and the veins decreases, your water retention reverses, your blood volume declines, your peripheral and pulmonary edema decreases, and your overall water weight is lost. So in addition to exercise tolerance and improving the fatigue that it would cause, there is, however, one important caveat. Although digoxin can produce a substantial improvement in heart failure, like your heart failure symptoms, it does not prolong life. So there is a question of why that is, and it's still unfortunately being discussed at this time. So your neurohormonal benefits in heart failure. At dosages below those needed for a positive inotropic effect, digoxin can modulate the activity of neurohormonal systems, the underlying mechanism in the inhibition of that sodium-potassium ATPase. In the kidneys, digoxin can suppress renin release. By inhibiting the sodium-potassium ATPase in the renal tubules, digoxin decreases tubular absorption of sodium. So, as a result, less sodium is present in the distal tubule, so renin release is suppressed. Through effects on the vagus nerve, digoxin can decrease sympathetic outflow from the central nervous system, specifically by inhibiting sodium-potassium ATPase in vagal afferent fibers. Digoxin increases the sensitivity of cardiac baroreceptors. As a result, these receptors discharge more readily, thereby signaling the CNS to reduce sympathetic traffic to the periphery. So how important are these effects on renin and your sympathetic tone? Well, no one knows that for certain. However, they are probably just as important as an inotropic effect, and perhaps even more important. So, the electrical effects on the heart. The effects of digoxin on the electrical activity of the heart are of therapeutic and toxicologic importance. It's because of the electrical effects that digoxin is useful in treating a dysrhythmia, for instance. Well, and again, that was discussed in chapter 41. Ironically, these same electrical effects are responsible for causing dysrhythmias. So it's also the most serious adverse effect of digoxin. It can help treat a fatal dysrhythmia. It can also cause it. So the electrical effects of digoxin can be bewildering in its complexity. Through a combination of actions, digoxin can alter the electrical activity in the non-contractile tissue, so your sinoatrial SA node and atrioventricular AV node, as well as the Purkinje fibers, as well as in the ventricular muscle. In these various regions, digoxin can alter automaticity, your refractoriness, and the impulse conduction. So whether these parameters are increased or decreased depends on the cardiac status, digoxin dose, and the region involved. Although the electrical effects of digoxin are many and varied, only a few are clinically significant. And these are going to get discussed next. So, mechanisms for altering electrical activity on the heart. Again, digoxin alters the electrical properties of the heart by inhibiting your sodium-potassium ATPase and by enhancing the vagal influence of the heart. By inhibiting that sodium-potassium ATPase, digoxin alters the distribution of the ions, sodium, potassium, calcium, across the cardiac cell membrane. This change in the ion distribution can alter the electrical responsiveness of cells involved. Because hypokalemia intensifies the inhibition of sodium-potassium ATPase, hypokalemia intensifies alterations in the cardiac electrical properties. Digoxin acts in two ways to enhance vagal effects on the heart. First, the drug acts in the CNS to increase the firing rate of vagal fibers that innervate the heart. Second, digoxin increases the responsiveness of the SA node to acetylcholine. Again, that's that neurotransmitter released by the vagus. The net result of these vagotonic effects is a decrease in atomicity of the SA node and a decreased conduction through the AV node. So, its effects on specific regions of the heart. In the SA node, digoxin decreases atomicity by the vagotonic mechanisms just mentioned. In the AV node, digoxin decreases the conduction velocity and prolongs the effective refractory period. These effects, which can promote varying degrees of AV block, result primarily from the drug's vagotonic actions. In the Purkinje fibers, digoxin-induced inhibition of sodium-potassium ATPase results in the increased atomicity. This increase can generate ectopic foci that, in turn, can cause ventricular dysrhythmias. In the ventricular myocardium, digoxin acts to shorten the effective refractory period and possibly increase atomicity. So, what are your adverse effects then? Your cardiac dysrhythmias. Dysrhythmias is the most serious adverse effect of digoxin. They result from altering the electrical properties of the heart. Fortunately, when used in doses recommended by today, the dysrhythmias are considered uncommon. Digoxin can mimic practically all types of dysrhythmias, whether it's an AV block with an escape beat, which is among the most common. It can also trigger your ventricular flutters and your ventricular fibrillation, which are the most dangerous. Because serious dysrhythmias are the potential consequence of therapy, all patients need to be evaluated frequently for changes in your heart rate and rhythm, and any kind of significant changes that do occur, digoxin should be withheld. So, there is a patient education portion that we really need to provide our patients, and that is monitoring their heart rate. Patients should be taught to monitor their pulse and be instructed to report any significant changes in their rate or regularity. So, the mechanism of a ventricular dysrhythmia generation. Digoxin-induced ventricular dysrhythmias result from a combination of four factors. Again, the first one, a decreased atomicity of that SA node. The second, a decreased impulse conduction through the AV node. Third, the spontaneous discharge of Purkinje fibers, caused in part by that increased atomicity. And finally, a shortening of the effective refractory period in ventricular muscles. So, increased Purkinje fiber discharge and the shortening of the ventricular effectiveness, that refractory period, predisposes the ventricles to developing an ectopic beat. Potential ectopic beats become manifested because of the effects of digoxin on the SA and AV node, and decrease the ability of the normal pacemaker to drive the ventricles, allowing for ventricular ectopic beats to take over. Your ventricular ectopic beats pretty much is your ventricular tachycardia, or VTAC. Predisposing factors. Your hypokalemia. The most common cause of dysrhythmias in patients receiving digoxin is hypokalemia, secondary to the use of a diuretic. Less common causes include vomiting and diarrhea. Hypokalemia promotes dysrhythmias by increasing digoxin-induced inhibition, again of that sodium-potassium ATPase, which in turn leads to the increased atomicity of Purkinje fibers. Again, because low potassium can precipitate dysrhythmias, it is imperative that a serum potassium level be kept within the normal range. If a diuretic therapy causes potassium levels to fall, a potassium-sparing diuretic, such as aldactone or spironolactone, needs to be prescribed to correct the problem. Your potassium supplements also could be used, and patients should be taught to recognize those symptoms of hypokalemia, again, that muscle weakness, and be instructed to notify the prescriber if these develop. So, elevated digoxin levels. Your digoxin has, again, a very narrow therapeutic range. So drug levels only slightly higher than therapeutic greatly increase the risk for toxicity. Possible causes of an excessive digoxin level could include intentional or accidental overdose, but also increased digoxin absorption or potentially a decreased digoxin elimination. So if the digoxin levels are kept within an optimal therapeutic range, which is considered to be 0.5 to 0.8, the chance of a dysrhythmia will be reduced. However, it is important to note that a careful control over the drug levels does not eliminate the risk. As discussed previously, there is only a loose relationship between a digoxin level and the clinical effect. So as a result, some patients may experience a dysrhythmia even when the drug level is within what is considered a normal range. Heart disease. The ability of digoxin to cause dysrhythmias is greatly increased by the presence of heart disease. Doses of digoxin that have no adverse effects on the healthy volunteers can precipitate serious dysrhythmias in patients who have heart failure. The probability and severity of the dysrhythmia are directly related to the severity of the underlying disease process. Because heart disease is the reason for taking digoxin, it should be no surprise that people taking the drug are at risk for having a dysrhythmia. So diagnosing digoxin-induced dysrhythmias. The diagnosis is not relatively easy, largely because the failing heart is prone to spontaneous dysrhythmias as is. Therefore, when a dysrhythmia does occur, we cannot simply assume that digoxin is the cause. The possibility that the dysrhythmia is the direct result of heart disease must be considered as well. The compounding diagnostic difficulties is the poor correlation between a plasma digoxin level and a dysrhythmia onset. Because of this loose association, the presence of an apparently excessive digoxin level does not necessarily indicate that digoxin is responsible for the problem. Your lab data requires for diagnosing include or should include your digoxin level, your overall serum electrolytes, as well as an EKG. Ultimately, diagnosis is based on the experience and clinical judgment, and its resolution of the dysrhythmia after digoxin withdrawal may confirm the diagnosis, but again, it may not even be the cause. So, managing digoxin-induced dysrhythmias. So, if you do know it's caused by digoxin, with proper treatment, digoxin-induced dysrhythmias can almost always be controlled. Basic management measures are as follows. Common sense, withdraw digoxin and potassium-wasting diuretics. For many patients, no additional treatment is even needed. To help ensure that the medication is stopped, a written order to withhold digoxin should be made. Monitoring our serum potassium. If your potassium level is low or nearly normal, your potassium should be replaced. Potassium displaces digoxin from your sodium-potassium ATPase and therefore helps reverse toxicity. However, if potassium levels are high or if the AV block is present, no more potassium should be given. Under those conditions, more potassium may cause a complete AV block. Some patients may require an antidysrhythmic drug, so the drug of choice at that point would be your phenytoin and lidocaine, which are most effective. Quinidine is another antidysrhythmic drug which can cause plasma levels of digoxin to rise and so should not be used. Patients who develop bradycardia or an AV block may be treated with atropine. Again, atropine blocks the vagal influences that underlie bradycardia and AV block. Alternatively, electronic pacing can also be employed. When overdose is especially severe, digoxin levels can be lowered using a Fab antibody fragments, also known as Digibind or Digifab. After IV administration, these fragments bind to digoxin and therefore prevent it from acting. Treatment, however, is extremely expensive, and a full neutralizing dose can cost anywhere between $2,000 to $3,000. Cholestyramine, oh my goodness. Cholestyramine and activated charcoal agents also work on binding on digoxin and can be administered orally, which suppress the absorption of the digoxin through the gastrointestinal tract. Other adverse effects, your non-cardiac adverse effects. The principal non-cardiac toxicities of digoxin concern the GI system and your central nervous system, because adverse effects on these systems frequently precede the development of a dysrhythmia. Symptoms involving the GI tract and the CNS can provide an advanced warning of more serious toxicity to come. Accordingly, patients should be taught to recognize these effects and be instructed to notify the prescriber if they start to occur. The first being anorexia, nausea, and vomiting, which are the most common GI side effects. These responses result primarily from the stimulation of a chemoreceptor trigger zone in the medulla, which digoxin rarely can cause diarrhea. Again, the reason for the anorexia, nausea, and vomiting, as well as the potential low cause of diarrhea, would be then that potassium. If you're throwing it up, it's going to be low, and a low potassium is dangerous. Fatigue is the most frequent CNS side effect. Visual disturbances, such as blurred vision, a yellow tinge to your vision, or the appearance of starting to see halos around dark objects, are also relatively common. More adverse effects. Measures to reduce adverse effects. So your patient education on digoxin toxicity. Patients should be warned about digoxin-induced dysrhythmias and be instructed to take their medications exactly how they're prescribed. In addition, they should be informed about symptoms of developing toxicity, again, that altered heart rate, rhythm, visual, or GI disturbances, and be instructed to notify the prescriber if these develop. If a potassium supplement or a potassium-sparing diuretic is part of the regimen, it should be taken exactly as ordered. You should also probably add to this, which isn't written down, what to do if a patient missed a dose, in case they think, hey, I should double down with the next dose. Dangerous stuff. So, drug interactions. Digoxin is subject to a large number of significant drug interactions. Some are pharmacodynamics, and some are pharmacokinetic. Several important interactions are going to get discussed later, but this following table here is an outstanding spot to hit pause so you can see how certain medications will interact with digoxin. So I'll leave that up for just a moment. Again, hit pause. So we'll talk a little bit on diuretics here. Your thiazide diuretics and your loop diuretics promote loss of potassium and therefore increase the risk for a digoxin-induced dysrhythmia. Accordingly, when digoxin and these diuretics are used concurrently, a serum potassium level must be monitored and maintained within a normal range. If hypokalemia starts to develop, your potassium levels need to either be restored with a supplement by starting a potassium-sparing diuretic or a combination of both. The ACE inhibitors. Again, these drugs can increase potassium levels and can therefore decrease the therapeutic response to digoxin. So we need to exercise caution when we're using ACE inhibitors or ARBs in combination with a potassium supplement or a potassium-sparing diuretic. So we may need to transition them to a non-sparing diuretic. Your sympathomimetics. So sympathomimetic drugs, your dopamine or dobutamine, which act on the heart to increase the rate and force of contraction. The increase in contractile force can add to the positive inotropic effect that digoxin already offers. These complementary actions can be beneficial. In contrast, the ability of sympathomimetics to increase heart rate may be detrimental in that the risk for tachydysrhythmia is potentially increased. Your quinidine. Quinidine is an antidysrhythmic drug that can cause plasma levels of digoxin to rise. Again, quinidine increases digoxin levels because it's displacing digoxin from tissue binding sites and by reducing renal excretion of digoxin. By elevating the levels of free digoxin, quinidine can promote digoxin toxicity. Accordingly, concurrent use of quinidine and digoxin should be avoided, or both dosages may need to be decreased severely. Your verapamil. Verapamil, again, that's a calcium channel blocker, can significantly increase plasma levels of digoxin. If the combination is employed, digoxin dosage must be reduced. In addition, verapamil can suppress myocardial contractility and can therefore counteract the benefit of digoxin. Your pharmacokinetics, your absorption. Absorption with digoxin tablets is variable, ranging anywhere between 60 and 80%, and can be decreased with certain foods and other drugs. Meals high in bran can decrease absorption significantly, and as can cholestyramine, your pectin, and certain other drugs. Again, that table that we talked about where you need to hit pause. Of note, taking digoxin with meals decreases the rate of absorption, but not the extent of its use. In the past, there was considerable variability in the absorption of digoxin from tablets prepared by different manufacturers. This variability resulted from differences in the rate and the extent of tablet dissolution. Because of the variable bioavailability, it had been recommended that patients not switch between different digoxin brands. Today, bioavailability of digoxin in tablets produced by different companies is fairly uniform, making brands of digoxin more interchangeable than in the past. So it's a little safer today. However, given the narrow therapeutic range of digoxin, some authorities still recommend that patients don't switch between different brands of their tablets, even when the prescriptions are written generically except with the approval of the supervision of the prescriber. Its distribution. Digoxin is distributed widely and crosses the placenta. High levels are achieved in cardiac and skeletal muscle, owing largely to binding of sodium-potassium ATPase. About 23% of digoxin in plasma is bound to proteins, mainly albumin. Its elimination. Digoxin is eliminated primarily through the renal excretion. Hepatic metabolism is minimal. Because digoxin is eliminated by the kidneys, renal impairment can lead to toxic accumulation. Accordingly, dosages must be reduced if kidney function declines. Because digoxin is not metabolized to a significant extent, changes in liver function don't necessarily affect digoxin levels. Its half-life and time to plateau. The half-life of digoxin is about 1.5 days. Therefore, in the absence of a loading dose, which is about 6 days or 4 half-lives, are required to reach plateau. When use of a drug is discontinued, another 6 days is required for digoxin stores to be completely eliminated. Your single dose course. The effects of a single oral dose begin 30 minutes to 2 hours after the administration and can peak within 4 to 6 hours. A note on plasma digoxin levels. So, levels above 1 ng per ml offer no additional benefits, but do increase the risk for toxicity. Knowledge of plasma levels can be useful for the following: establishing a dosage, monitoring compliance, diagnosing toxicity, determining the cause of a therapeutic failure. After a stable blood balance or blood level has been achieved, routine measurement of digoxin levels can be replaced with an annual measurement. Additional measurements may be helpful in the following circumstances. If, for instance, your digoxin dosage has changed, if your symptoms of heart failure have increased or intensified, your kidney function starts to deteriorate, and signs of toxicity may begin. Drugs that also can affect your digoxin levels should be, monitored and assessed, and if need be, we need to check your digoxin level. Although knowledge of digoxin plasma levels can help aid the clinician, it must be understood that the extent of this aid is limited. The correlation between plasma levels of digoxin and clinical effect, both therapeutic and adverse, is not very tight. Drug levels that are safe and effective for patients A or for patient A may be subtherapeutic for patient B and toxic for patient C. Because the interpatient variability knowledge of digoxin levels do not permit precise predictions of therapeutic effects or toxicity. So therefore, the information regarding drug levels must not be relied on too heavily. Rather, this information should be seen as but one factor among several to be considered when we are evaluating the clinical response. So how is it prepared, the dosage and administration? Digoxin is available in 3 formulations: a tablet, a pediatric elixir, and the solution for a potential injection. The administration: digoxin can be administered orally and IV. Intramuscular administration should be avoided owing to the risk for tissue damage and severe pain. Before dosing, the rate and regularity of the heartbeat should be determined. Again, if that heart rate is less than 60 beats per minute, or if there's a change in the rhythm, digoxin should be withheld, and the prescriber ought to be notified. When digoxin is given intravenously, the cardiac status must be monitored continuously for at least 1 hour to 2 hours. The dosage in heart failure. Most patients can be treated with the initial and maintenance dose of 0.125 to 0.25 milligrams per day. Doses above 0.25 milligrams per day are rarely used or needed. The target plasma drug level is only 0.5 to 0.8 ng per ml. So the term digitalization refers to the use of a loading dose to achieve a high plasma level of digoxin quickly. Again, as noted, 6 days are needed for the drug levels to reach a plateau if no loading dose was employed. Although digitalization was common in the past, this practice is now considered unnecessary and technically inappropriate at this point, especially in the treatment of chronic heart failure. Which brings us to the management of heart failure. Our clinical discussion of heart failure management is based on the recommendation in the 2013 ACCF-AHA guideline for the management of heart failure. Executive Summary, a report of the American College of Cardiology Foundation and the American Heart Association Task Force on Practical Guidelines or Practice Guidelines. Again, you can see these guidelines here on this website by the AHA journals. And again, as noted earlier, these guidelines approach heart failure as a progressive disease which advances through 4 stages or 4 levels of increasing severity. The management for each stage is discussed next. So again, here you're taking a look at a picture where you see the different stages, whether you go by the numbers or A, B, C, D. So, these management measures are consistent with those in another guideline, again, the HFSA 2010 Comprehensive Heart Failure Practice Guideline, which was issued by the Heart Failure Society of America. In addition to the discussion of heart failure and left ventricular systolic dysfunction, the HFSA guideline addresses other issues, including the acutely decompensated heart failure or heart failure, preserved left ventricular ejection fraction, and heart failure in special populations. So we'll start with stage 1 or stage A. Again, by definition, patients in this group have no symptoms of heart failure and no structural or functional cardiac abnormalities, but they do have behaviors or conditions strongly associated with developing heart failure. Important among these are the hypertension, coronary artery disease, diabetes, a family history of cardiomyopathy, and the personal history of alcohol abuse, rheumatic fever, or the treatment of a cardiotoxic drug. The management is directed at reducing the risk. Again, hypertension, hyperlipidemia, and diabetes need to be controlled as best as possible, as should ventricular rate in patients with supraventricular tachycardias. An ACE inhibitor or an ARB can be useful for patients with diabetes, atherosclerosis, or hypertension. Your patients should cease behaviors that would increase the risk for heart failure, especially if you're still smoking or drinking alcohol. Excessive consumption of alcohol is the leading cause of cardiomyopathy. In a patient with heart failure, acute alcohol consumption can suppress contractility. There's currently no evidence that getting regular exercise can prevent the development of heart failure. Although exercise does have other health benefits, routine use of dietary supplements to prevent structural heart disease is not recommended. Which takes us to stage B or number 2, depending on how you want to go with this route. Like patients in stage A, those in stage B have no signs or symptoms of heart failure, but they do have a structural heart disease that is strongly associated with the development of heart failure. Among the structural changes is a left ventricular hypertrophy or fibrosis, the left ventricle dilation or hypocontractility, valvular heart disease, and the previous myocardial infarction. The goal of management is to prevent the development of symptomatic heart failure. The approach is to implement measures that can prevent further cardiac issues, delaying the progression of remodeling and left ventricular dysfunction. Specific measures include all those discussed for stage A or 1. In addition, treatment with an ACE inhibitor plus a beta blocker is recommended for all patients with a reduced ejection fraction, history of myocardial infarction, or both. For patients who cannot tolerate an ACE inhibitor, an ARB may be used instead. As in stage A or 1, there is no evidence that using any kind of dietary supplements or getting regular exercise can help prevent the progression of symptomatic heart failure. Which brings us to stage C, or 3. Patients in stage C have symptoms of heart failure and also have structural heart disease. So your symptoms could include your dyspnea, fatigue, peripheral edema, and that distension in your jugular veins. Treatment has 4 major goals. Again, the relief of pulmonary and peripheral congestion symptoms, the improvement of the functional capacity and the quality of life, and slowing the cardiac remodeling and progression of the left ventricular dysfunction. And finally, again, we want to make sure that we are able to prolong the life. Treatment measures include the recommendation for stages A and B, plus those that are going to get discussed here. So, your drug therapy. Drug therapy for heart failure has changed dramatically over the past 15 to 20 years. Again, formerly, digoxin was a mainstay of treatment. Today, its role is secondary. Your first-line therapy consists of 3 drugs, a diuretic, an ACE inhibitor, or an ARB, and a beta blocker. And as a rule, Digoxin is added only when the symptoms can't be managed with the prior three. So, again, diuretics. All patients with evidence of fluid retention should restrict salt intake and use a diuretic. Your diuretics are only reliable means of correcting your fluid overload. Furthermore, drugs produce symptomatic improvement faster than any other drug. If your renal function is good, a thiazide diuretic will work. However, if renal function is significantly impaired, as it is in most patients, a loop diuretic may be needed. Efficacy of diuresis is best assessed by the daily measurement of body weight. After fluid overload has been corrected, diuretic therapy should continue to prevent recurrence. Your diuretics should not be used alone. Rather, for most patients, they should be combined with an ACE inhibitor or an ARB plus a beta blocker. Because aspirin and other non-steroidal anti-inflammatory drugs can decrease the effect of diuretics and increase the incidence of acute kidney injury when used in combination with an ACE inhibitor and a diuretic, these agents should be avoided. As noted, although diuretics reduce symptoms, again, they don't prolong life. Speaking back on ACE inhibitors and ARBs, in the absence of specific contraindications, again, the big ones would be pregnancy. All patients with stage 3 or C heart failure should receive an ACE inhibitor. If fluid retention is evident, a diuretic should be used as well. Symptomatic improvement can take several weeks or even months to develop. However, even in the absence of symptomatic improvement, ACE inhibitors can prolong life. Dosage should be sufficient to reduce mortality. So, for patients who cannot tolerate an ACE inhibitor, ARBs remain the recommended alternative. And again, that last one, beta blockers. In the absence of specific contraindications, all patients with stage 3 or stage C heart failure should receive an approved beta blocker, so your corvedolol or Coreg. As with ACE inhibitors, symptomatic improvement may not be evident for several months. Nonetheless, it may prolong your life, even if the absence of clinical improvement is absent. Your aldosterone antagonists. Adding an aldosterone antagonist, your spironolactone or eplerenone, to standard therapy is reasonable in patients who have moderate, severe, or severe symptoms of heart failure after a heart attack. However, aldosterone antagonists must not be used if your kidney function is impaired or your serum potassium levels are elevated. Monitoring your renal function and potassium levels is imperative. Which brings us back to digoxin. Digoxin may be used in combination with ACE inhibitors or ARBs, your diuretics, and beta blockers to improve your clinical status. However, although digoxin can reduce symptoms, it does not prolong life. Again, the usual dose is 0.125 to 0.25 milligrams per day. Your adjustments are based on the clinical response, and digoxin may be started early to help improve symptoms, or it may be reserved for patients who don't respond adequately to diuretics, ACE inhibitors, or ARBs, or even their beta blocker. Bringing us lastly to your combo drugs, your isorbidide dinitrate or with hydralazine, which is recommended to improve outcomes in self-described African American people who have a moderate to severe symptom, despite optimal therapy with ACE inhibitors, beta blockers, and diuretics. Again, for all other patients who continue to have symptoms despite treatment with standard therapy, by adding this combo drug to the regimen, it's considered reasonable. For patients who can't tolerate ACE inhibitors or ARBs, the substitution of the combo drugs is also considered reasonable. Drugs that we need to avoid. Patients, again, in the stage C or stage 3 group should avoid 3 classes of drugs: your antidysrhythmics, your calcium channel blockers, and your NSAIDs. Reasons for not using these drugs are for the following reason. So, your antidysrhythmic agents. These drugs need to need to be avoided because they have a cardiosuppressant and pro-dysrhythmic action that can make heart failure even worse. Only two agents, your amiodarone and ticagrelor, have been currently approved that would improve your survival rate. Your calcium channel blockers. Again, these drugs make heart failure worse and may increase the risk for adverse cardiovascular events. Only the long-acting, your dihydropyridine calcium channel blockers, such as your amlodipine or Norvasc, has been shown not to reduce survival. And lastly, your NSAIDs. These drugs promote the sodium retention and peripheral vasoconstriction. Both actions make your heart failure worse. In addition, your NSAIDs can reduce the efficacy and intensify the toxicity of your diuretics and ACE inhibitors. Therefore, even though aspirin has beneficial effects on your coagulation, it shouldn't be used because of conditions that could trigger myocardial infarctions. So, evaluating our treatment. Evaluation is based on symptoms and physical findings. The reductions in dyspnea on exertion, paroxysmal nocturnal dyspnea, and orthopnea indicate a success. The physical exam should assess for the reductions in your jugular distension, edema, and crackles in the lungs. Success is also indicated by the increased capacity for physical activity. Patients should be interviewed to determine the improvement in the maximal activity they can perform without any symptoms, the type of activity that is regularly produced, symptoms, and maximal activity they can tolerate. Successful treatment should also improve the health-related quality of life in general. Therefore, the interview should look for improvements in sleep, sexual function, outlook on life, cognitive function, and the ability to participate in usual social, recreational, and work activities. Routine measurement of ejection fraction or maximal exercise capacity is not recommended. Although the degree of reduction in ejection fraction measures at the beginning of therapy is predictive of outcome, improvement in the ejection fraction does not necessarily indicate that the prognosis has changed. Again, as noted earlier, the reduction in the circulating BNP indicates an improvement. The lower the BNP, the better the odds of long-term survival. And lastly, stage D or stage 4. Patients in stage D have advanced structural heart disease and marked symptoms of heart failure at rest. Despite treatment and maximal dosages of medications used in stage C, repeated and prolonged hospitalization is common. For eligible candidates, the best long-term solution is a heart transplant. An implantable left ventricular mechanical assist device can be used as a bridge in patients awaiting a transplant and to prolong life in those who are not transplant eligible. Management focuses largely on the control of fluid retention, which underlies most signs and symptoms. The intake and output should be monitored closely and the patient should be weighed daily. Fluid retention can usually be treated with a loop diuretic, perhaps combined with a thiazide. If volume overload becomes severe, the patient should be hospitalized and given IV diuretics. If needed, an IV inotropic agent can be added to increase the renal blood flow, therefore enhancing diuresis. Patients should not be discharged until stable and effective oral diuretic regimen has been re-established. These drugs again are going to be discussed further in Chapter 89. Beta blockers and ACE inhibitors may be tried, but doses should be low and responses should be monitored with care. In stage D or stage 4, beta blockers pose a significant risk for making heart failure worse, and ACE inhibitors may induce profound hypotension and renal failure. When severe symptoms persist, despite application of all recommended therapies, options for end-of-life care should be discussed with the patient and family. And that concludes our chapter here for today. As always, I thank you for listening, and I'll see you at the next chapter. Till then, take care.